Good afternoon, everyone. My name is Sue Botello, and I'm one of the professional practice associates at the college. Thank you for joining us today for this panel discussion. It's called Navigating Confidentiality in Non-Healthcare and Multidisciplinary Settings. Before I introduce our panelists, I'll go over a few housekeeping items. This session has live captions. To turn on the captions, click the Show Captions button below the video player. You can choose to see the live captions in either English or French. If you need tech support, please use the support chat at the bottom left-hand corner of your screen. Click on the icon and you will be connected with our live support. There will be an opportunity to ask questions at the end of the session. You can submit your questions through the chat feature on the right-hand side of the session page on the virtual portal. Now, let's begin this educational session. I'm extremely pleased to have some incredible people here at the table as our panelists who will speak today about confidentiality in various settings. First, I'll introduce Ashley Bernardi. Ashley is the Manager of Social Work at the Roy McMurtry Youth Center. And then we have Michelle Brisebois, Chief Privacy Officer of Quality and Risk at Mamwasing North Shore Community Health Services. And we have Alicia Cara, Youth Center Deputy Administrator at the Roy McMurtry Youth Center. And then we have Teresa Risatelli, Interim Manager of Social Work at the York Region District School Board. You can read the full biographies of our panelists on the virtual portal. Please join me in welcoming our panelists. Thank you all for being here today. I will say before we start our questions that this topic often comes up in professional practice. We must get maybe one a day in terms of questions around how to navigate issues of confidentiality and sharing information when people are working in settings that are not amongst social work or colleagues that follow the different legislation for privacy. So we are very, very pleased that you are all here volunteering to speak with us today and give us some insight about your experiences in different settings and the challenges that you may face as well. So we're so happy, or maybe it's just that I'm very so happy because this is something that I know that our registrants will really, really appreciate. So I'll get started just by asking a few questions, and I'm going to ask among the table here, and please feel free to add on to anybody's sort of comments or feedback, and if you're feeling like you want to add, please, go ahead and do that. We have some really hopefully some very helpful questions that may trigger other things along the way. So I want to begin with Alicia. Alicia, can you provide us with specific insights from your practice setting and work with clients in a non-health environment? And then I would follow that as well with Teresa and Ashley.
Sure.
Thank you.
Good afternoon, everyone. I'll give a little bit of context in terms of where I'm from, in terms of the background of the professional setting. So the Roy McMurtry Youth Center is a secure detention custody facility that's based in Brampton, Ontario, so the Greater Toronto area. And essentially, it's a facility that houses male or male-identifying youth that would have had to have been charged before their 18th birthday. So according to the legislation that we kind of primarily use, it's the federal legislation, which we refer to as the Youth Criminal Justice Act, the YCJA. And that essentially is for youth who would have had to have been charged between the ages of 12 and 17, but again, like I said before, their 18th birthday. So RMYC is a direct operated facility. And when I say direct operated, what that means is that it's government owned, government funded, government run. And that's obviously important because it's different from, for example, like a transfer payment agency where it might be government funded, but not government owned or run. So there's different provisions, there's different policies and procedures, there's different requirements in terms of how they operate. Also important to note is that it is a remand facility. So when I say remand, what that means is that the youth are there still with the court proceedings before them. So whereas there are, other places that have a predominantly large number of sentenced youth, our facility has a large number of remand youth. So our current capacity right now is 112 youth. And if we're kind of looking at numbers on any given day, we probably have up to maybe 8 or 9 that are sentenced and the rest that are remand. So that'll kind of play a role in the conversations to come in terms of how that impacts some of the confidentiality pieces as well. So just kind of dropping that piece right now. Quick little synopsis in terms of how we operate, because I think just from my experience of talking about corrections or youth justice with a number of social workers from other settings, there's not always an understanding because it is kind of like a niche role for social work. And so the way that we operate is that it is kind of like a campus-style setting. However, it is secure, which means that in terms of the continuum, it's the most severe. So in terms of if you wanted to compare it or liken it to adult corrections, it's kind of like maximum, right? And that is the setting that we currently are in. There's 2 intake units that exist in the space. And so in those intake units, the youth would be there for up to 14 days where there's information gathering, collection of information from various professionals that occurs. And then after that, they would go into a regular living unit where they would spend weeks, months, sometimes years in that space as well. We have a multidisciplinary team that exists within the facility. So anywhere, in terms of departments, we have healthcare, social work, psychology, chaplains, spiritual life, recreation officers, youth service officers. So if I use the term YSO, that refers to youth service officer, and that is kind of comparable to a correctional officer, and then managers and the like as well. So it's very multidisciplinary in that sense. Specific to the social work team, Ashley is from the same setting, so she'll probably talk a little bit more specifically about the team, but we do have 8 social workers within that team with a combination of experience that exists with their BSW and or MSW, and each of them have a caseload of up to 14 youth on their units, and they act as in the case coordinator capacity, where they kind of quarterback the entire case management process for each youth that's on their unit. In terms of touch points where the work is kind of not obviously health related, I think one of the important pieces to mention off the bat is that there's a lot of intersectionality that exists in our setting. Just because we're not necessarily primarily a healthcare setting, there still is, like I mentioned, many systems that we touch base with on a regular basis, including the healthcare system, the education system, the child welfare system. So there's a lot of intersection that does exist on a daily basis with professionals within the space.
Thank you. That's been very helpful. Did you want to also answer that, Teresa, or do you want to finish up and wrap up the correctional piece first?
I can speak to some of the specific examples in terms of non-healthcare. I mean, a lot of the expectations are similar in terms of requiring consent and securing information and how information is stored. A big piece of it for us is allowing young people that have the capacity to consent to have that opportunity to consent, regardless of age. If the capacity is there to understand the parameters around the decision making, we want to make sure that we're providing that and making sure that they're informed in terms of what it is that they're agreeing or disagreeing with or to. And one of the biggest things for us is balancing confidentiality with safety and understanding that confidentiality is only insofar as you yourself or others are not at risk of harm.
Mm-hmm. Okay, so that's really clear to the youth. They're aware of that.
Absolutely.
Thank you very much. Teresa, maybe give us some insight on your workplace setting?
Yeah. So at the York Region District School Board, we're a team of 65 social workers. Each social worker carries anywhere between 5 to 8 schools. And that could, over the school year, run up to 100 students on a particular caseload at any given time. And the support that they provide, we're supporting students from K to 12. and we're providing individual, group, case management, crisis support. And all of these supports are done while interfaced with parents, administrators, teachers, healthcare, psychologists, etc. And social workers, given the assignment, are also immersed in the school community. So we sit in lunchrooms and we're collaborating with teachers. We are attending their team meetings, etc. So many of those things can sometimes present a challenge when we are discussing students.
Thank you. Very helpful. So for Michelle, we know you work with the family health team and specifically with other professionals, but you also then collaborate or interface with non-health professionals as well. But in terms of your multidisciplinary setting, we know that your organization, you're working as one, as in Ojibwe. And so we wondered, how does this collaborative concept, as well as the concept of the circle of care, come into play with your work?
I asked for this to be put up because our model of care looks very different than the Western one. Indigenous model of care, spiritual is always first. That's never in the model of care for the Western world. Spiritual, emotional is separate from spiritual, mental, and physical. So this really kind of just gives you an idea of what our model of care is, and what our circle of care looks like. Our organization provides primary care, home and community support services, mental health and addictions, and we also have a crisis team. Because we service 11 First Nation communities, obviously the Indigenous population is our focus, but we also service the community members who are non-Indigenous who are living in our communities. But our circle of care, as I talked about, is nice that we do provide all those delegations because our mental health workers can speak to our physicians, can speak to, if somebody needs physio, those kind of things. We don't have to worry so much about consent from the client. I guess if they're one of our clients and they're accessing our services, we have their consent for that. What we do have to worry about, as you can imagine, with our communities being small, some with only 200 people population, our employees are our clients and vice versa. Our communities are small. I'm not sure if any of you are familiar with Indigenous communities. We're all related to each other, right? So confidentiality, we have to be even more careful, right? You could get a fax at the health center and it could be somebody's niece that's getting that fax and knows something about auntie that they shouldn't know. So we really take privacy very seriously within our organization, and how we're storing information and keeping our clients aware of what their rights are, basically. If they want lock boxes installed, put on their charts, those kind of things. So I think we're a little bit different, maybe.
Mm-hmm. No, I think it's important to know that when you're working in a medical setting or a primary setting like that, you are looking at circle of care, which Absolutely. Can be active, but at the same time, because of the small communities, having that vigilance and ensuring that your first priority is that confidentiality of the person accessing services. That's going to always be probably like forefront in everything Absolutely. That you do, and how, from intake to termination, it's probably, like one of the first things, or always along the way, your consideration.
And to be honest with you, our mental health and addictions department, that's probably where we work on a lot, because that is very, very sensitive. If someone's receiving, addictions therapy, they may not want their community to know, which I just talked about is very hard when we're dealing with very small communities.
Absolutely. Yeah. So that's a challenge. Thank you very much for that. So we just want to shift gears a little bit in just terms of providing some examples about your role. And so I thought I would start with Teresa, just the question being, can you share an example when you've encountered a situation where colleagues didn't understand your role as a social worker or your professional responsibilities? That's the first part of that. And then what are some competing concepts of confidentiality and privacy amongst the different practitioner and organizations you work with? Because as we know, you are working within the school setting, which can be a challenge, but also then an extension of that in terms of community work as well.
So this question prompted me to think about our referral pathway for social workers. So oftentimes referrals are generated from social work at school team meetings. So we are often invited. Student consent is provided to attend that meeting, and parent consent as well, up until the age of 18. So we sit there, we listen to the student profile, we listen to the presenting concerns, and then a social worker at that time will decide whether the referral is appropriate. And at that meeting, lots of information is shared. And sometimes information is shared, while with good intention, may not be relevant to the referral. And so oftentimes social workers are needing to have delicate conversations with school staff that, again, they're interfaced with on a daily basis. And oftentimes if a social worker is picking up a referral and that's shared with the school team, we're often finding that social workers are approached later on in the day, next week, next month, saying, hey, can we get an update? What's the progress of so-and-so? Hey, I have new information. Can I share that with you? And so social workers are having to have delicate conversations with school staff, teachers, administrators, even parents. Because oftentimes students will say, hey, parent can consent, my parent can consent, but I don't want them to know what information what's being shared here. So again, social workers are often having to have delicate conversations with many folks, school staff and parents. And I would also say teachers and administrators don't have the same limits of confidentiality and restraints and sort of restrictions that we do. And so we don't want to be seen. What I will say is it's often striking a balance between having relationships with school staff, because that's who we need to work with all year long, and having sometimes uncomfortable conversations about what we're needing to hear, wanting to hear, while also keeping students at the center.
Yeah. It's an excellent response. Like we know that a lot of social workers in school board settings have very similar challenges across the province. So I'm sure our registrants can kind of relate to that if they're in those roles as well, and just those competing relationships and pressures and how they can be ongoing and changing can definitely, create some difficulty in your role. So thank you for that. Maybe we will get Ashley, just maybe if you want to focus on that as well. So an example of when you'd encountered a situation where your colleagues didn't understand your role as a social worker or your professional responsibilities, and any competing concepts of confidentiality and privacy.
So two of the biggest examples I can think of within my setting is that, as Alicia mentioned, we have youth service officers who, rightfully so, do spend most of their time with the youth. However, social workers will meet with the youth privately, and there are things shared with the social worker that sometimes are expressly asked not to be shared with any other members of the interdisciplinary team. But this presents a problem when the youth service officers are saying something to the effect of, well, we're working with them the most. And so this information that they're sharing with you might be able to help us in our work with them. Right. And we end up having to say, well, no, we can't share. And then that causes a little bit of contention because are you trying not to be a team player? And it's more, no, it's not that. There's limits in terms of what can be shared. And the other example that I'm thinking of is even among the social work and psychology teams. Because as social workers, the case coordinators, a lot of our paperwork goes into the central file for the youth, whereas for psychology, it's not. So there are times that social work wants information from psychology, and psychology can't share certain information. So then we end up thinking, well, hold on a second, we're both clinical in our own capacities and working with the same youth. Why can't we share? So sometimes there's a lack of understanding that across disciplines and across professions, the expectations and legislation around confidentiality is different.
That's very helpful to know. So your information for social work goes into a main repository,
Yes.
but not the psychology.
Right.
Well, that's interesting.
Right.
And again, you're also competing with, those those individuals who may not follow the privacy legislation because they're following other legislation, like the youth service officers.
Right, and they don't have the same parameters.
Okay. Is there anything you'll add to that?
Yeah, definitely. It's interesting because persons can be working in our setting in space for years, multiple years, and still not necessarily have a clear idea of what social workers do, right? And in the space, the social workers kind of play like a three-pronged role. I kind of compare it to like a three-legged table, right? And essentially what that does is oftentimes kind of, because they're doing so much, there's the case management piece, there's the crisis management piece, there's the traditional kind of clinical piece that's all being done by the social worker. There's not always like a great understanding for what the role is, and that oftentimes creates some of these kind of misunderstandings that exist within the space in terms of what social workers do, what they cannot do, Jack and Jills of all type of thing. And contributing factors, rightfully so, in the space are things like the space is quite large. There's a high turnover of staff that occurs for various reasons. And then also just the fact that there's a number of professionals that exist within the space, right? So there's multiple disciplines that exist in the space. So, and in comparison, in terms of numbers, if you're looking at kind of total number of staff, we probably have upwards of 400 plus staff, and 8 of them are social workers, right? And so unless someone kind of actively seeks out that information in terms of what the role is, it's not always very clear, in addition to pieces around the confidentiality, consents, all that kind of stuff, because the understanding or the shared understanding of what Ashley just said right now is that we all work, in the same space. Why are we not privy to the same type of information that ultimately, is suited for the best outcome of the youth? And then because also within the space, there's various colleges and professional associations that these various people belong to, it's kind of like a homogenous line of thinking, right? It's like, it's the expectations of all should be similar in that sense, because there's not an understanding, or there's not a reason to necessarily understand unless the initiative is taken to say, okay, well, why is this done differently, right? Maybe it's a protective factor for the youth. Maybe it's not as a result of trying to hide or hoard information. It's a protective mechanism so that, for example, if a youth is in front of the court, this is not then used for further incriminating information type of thing, right? So there's not always that thought process that's put into some of the line of thinking that's, staff have. And so it's up to the clinicians or the social workers to kind of have that discussion with them on a regular basis. And that's why I guess, like, from my vantage point, overseeing the entire department and various departments that have to do with the rehabilitation of kind of clinical components within the facility, one of the things that I often very much encourage is to remember your audience, right? And that's one of the things that, we often talk about, is that that's going to be kind of one of your strategies or saving graces in terms of how you operate and function within the setting. So whether that be through documentation, whether that be through, meetings, whether that be through whatever it is, there has to be an understanding that it's a means to an end, and that document has to reflect something that's accurate, but at the same time may go outside of the building, right? It may go far-reaching to other organizations, other individuals that may not have context. So it's really important to have those pieces kind of spelled out really clearly. In terms of the competing priorities, the one piece Ashley kind of did already mention in terms of the not the shared understanding or the understanding from various disciplines, but it often tends to happen even within the clinical team. So when I talk about the clinical team within our facility, that is the social workers, the psychology team, and healthcare team. And even amongst that team in itself, right, there is some kind of rift and or friction that exists because social workers in our setting are not considered doing any work related to health care, right? And so they're not HICs, they're not the health information custodians, whereas in the psychology team and the healthcare team are. So their social workers are not technically a part of the circle of care, and that sometimes causes confusion for the social work team as well in terms of understanding why can't we be privy to the same information that other members of the clinical team are, right? And so that that, again, is a learning curve or a teachable moment for the teams to be able to understand that there might be consents that are required even amongst one another in terms of the facility for sharing of information, but again, as a protective mechanism and not just because we're doing things for the sake of doing them. Obviously, there might be some workarounds, there might be some ways to be able to have discussions and maybe not necessarily have them all, in documents, but it doesn't mean that we still don't follow kind of the same protocols that are required in order to kind of have the privacy and confidentiality measures in place for the youth that are in our space.
It's very helpful. Thank you. And so, Michelle, we would ask just the similar type of question, but knowing that you work within the healthcare setting, can you share an example of when you've encountered role confusion amongst your partner organizations? And again, what are some competing concepts of confidentiality and privacy amongst the different practitioners and organizations that you work with?
And again, this probably isn't going to be common to all of you. Role confusion definitely happens with our chief and council. Probably aren't. But our most of our chiefs and council members are under the assumption that they should be able to know both their community members, if that makes sense. That's very hard to navigate, especially if there's a crisis situation within the community. Extremely hard to navigate and must be done delicately. Another example that I can think of, role confusion, and we deal with this a lot, is with child welfare. Okay. I'm not sure even how to explain it. They just ask, a lot of times if the kids are in care, they will ask for documents pertaining to the parents. Not sure if any of you have encountered that, but we do encounter that. Definitely no, but we do encounter that as well. So I'm not sure if maybe that's another difference. But chief and council and anybody that's from an Indigenous community will get that. That's probably our biggest.
Right. And so we see, that some commonality just in terms of who you share things with, why, when, knowing that, in some areas we have social work providing what would be defined as healthcare and would be a health information custodian. And so some school boards have different structures or models to that as well. And understanding at what level that legislation binds you to the respect and self-determination of a young person or somebody who's accessing care, even though, like we've had, everybody here sort of comment that, there's always the understanding that there might be an outcome that might be helpful, but we know that the respect of that person's capacity to make that decision would kind of trump that. So unless, of course, there's risk to, we talk about self-harm to others, and that's something you discuss at the outset, I'm sure, in terms of your policies. So we do hear these things quite a bit, even from the college point of view, and being a health information custodian in a non-health information custodian setting. And then even beyond that, like the partner organizations who feel that, well, what happens, like, can I just call you? Or people will say to the college, a police officer is asking us a question, they want some information, and there's that, bit of intimidation around, well, what'll happen if I don't? Is there any consequence if I don't share information? And they start to question, where their responsibility lies.
It's funny that you're mentioning that, Sue, only because social workers at our board are often also navigating situations where, in session, a student will disclose they might have substances in their trunk, for example, or they let us know that a fight is going to break out at 3:30 in the parking lot and there's going to be a brawl. And social workers are often navigating, sort of the question that they're posing to themselves. Do I breach confidentiality here?
Yeah.
And who are we sharing it with? And also the question they're asking is the school community at risk? And oftentimes we're often put in this ethical dilemma, right? What do we share? What don't we share?
And I think there's that where that commonality may sort of diverge, because in your organizations you have a little bit more structure about the expectations, especially in an incarcerated setting, and where you're looking at a community of parents and teachers and people who all see themselves as, the village kind of thing.
Exactly.
Yeah, yeah. So,
And if we didn't share and that fight happened in the parking lot and somebody got hurt,
right. And then ongoing.
And even to speak to that a little bit further, oftentimes what you find, especially in a social work role, is you're being given a lot of information that you might not have a duty to report it, but it would be good to report it. But then you're also thinking about how you're jeopardizing your relationship with the client, right? And so you're constantly trying to weigh the benefit and the cost.
Right, to trust that it could be breached and as a result.
right?
Yeah.
And actually, there was a relevant example. It was a number of years ago, but even in terms of the information sharing. So obviously coming in, there's a number of, whether it be corporate initiatives or whatnot, and gathering information for different data sets or different kind of, outcome measures or whatever the case may be. And the one example that I can think of is that, they're obviously in the setting that we're in, there's a number of youth that have like very neighborhood entrenched or gang related type of issues. And there was some research that was trying to be done on that. And I think part of what they had wanted is for the social workers to be the individuals that collected that information from the youth. And so you can see how that would be really compromising in terms of the therapeutic relationship because of the information that was asked to be gathered directly from the social worker to the youth. And youth in that setting are already very skeptical as it is in terms of authority figures, in terms of anybody else in that space that, that has the power over. And because the social workers obviously play that therapeutic role, it became very clear that that was not the place or the person that should be kind of gathering that information for that cause. And so there was pushback that, ultimately was successful for that reason. But that's kind of, again, one of those pieces where until someone was to kind of, draw that out very clearly in terms of what the connection was, it wasn't very outwardly apparent to those that might not understand the nuances of what the role is, right?
Great point. Thank you. So we're just going to shift gears just in terms of general conversation or question. And I'd start maybe with Michelle in terms of what are your conversations about consent with clients look like? And what about your colleagues or partners? What are the differences?
With the consent piece, and I think this is important, we always share with our clients about lockboxes. We use lockboxes quite frequently in our organization so that they can protect part or all of their information, especially, again, because we have very close communities. So it's again, just about educating our clients about, what their rights are, what they can do with the information that we're collecting, using, and disclosing on their behalf. That is really, really important. And I think the clients honestly feel empowered because they have control. We're the health information custodians, but they own everything in it, right? So I would say that just educating them on what they can do with their information.
And that's a great point. And I think it's a bit of a plug for our privacy toolkit for the college too, because we do talk about lockboxes. And I think some of our registrants don't always see that as one sort of avenue or method of informing people that they have this ability to, have this saved and aside from everything else. And another reminder, thank you for that too, Michelle, is that that's not our records. Those are records that belong to clients. And at any moment and any given time, they're able to access that. So how are you documenting and writing and ensuring that you're respecting that? So I really appreciate those 2 points. Teresa, would you like to maybe address some of that as well? So what are your conversations about consent with clients? What do they look like?
So we actually spend a lot of time on informed consent and the consent process in education, only because social workers are immersed in the school community. So a lot of our conversations are spent with students talking about who do you want this information shared with, when, can I sit at team meetings? How much information would you like me to share? And always checking in with students, because sometimes what they may have shared on Tuesday at 4 might be a little different, Wednesday at 12 when we join the meeting. So it's constant check-ins, constant reiterating and being very clear about what information we're sharing, not speaking in generalities. Oftentimes we can get in a bit of trouble when we're speaking in generalities. Hey, Johnny, can I sit at a meeting? Often not telling them why we're sitting there, what information we'll be sharing. I will also say YRDSB, so York Region District School Board, has age of consent. So our age of consent is we must seek consent from student and parents up until the age of 18. And so other boards have adopted other ways and sort of age limits, and we're often having conversation with other boards about what makes sense, et cetera. So
that's a really good point too, because it is based on different policies and structures and organizations across the province.
Right.
But it's helpful to know what your colleagues are doing, right, in terms of how then you share amongst those individuals. Thank you. I mean, if Alicia, if you'd like to also speak to that, in terms of what your conversations around consent look like, and what your colleagues are with your colleagues or partners as well, and what are the differences?
Yeah, so as mentioned in the YCGA, confidentiality is a really important caveat that's a big part of the legislation in terms of protecting youth identity and all that. And it also emphasizes really the importance of like the accountability piece, but while protecting the rights of the young offenders. And so as a result of that, there is established kind of documentation that exists broadly, whether it be from the ministry and or the division, in terms of consents and in terms of limits of confidentiality and those pieces. And so for the youth, it's kind of off the bat during, admission and the first 72 hours that they're there when the social workers are to meet with them. That discussion generally takes place to kind of talk about those limits and what consents would look like. Now, because social work involvement is voluntary, it is one of those pieces where if they don't sign off, there's still, even though it is voluntary, case management would still continue, right? But the level of involvement would obviously look different in terms of that specific youth and the social worker. The social worker is based on the unit, and so there is direct involvement on a daily basis, but what that looks like would be different according to the consents that are kind of given, right? But the limits are always shared with them off the bat, and obviously those speak to, the caveats of the duty to report, if there's subpoenas from court that are requesting information, that kind of stuff. Obviously, imminent risk to self or to anybody else, those type of pieces are shared off the bat. But consents, if they refuse to sign, that is something that we have to be mindful and cognizant of, because it's happened plenty of times where youth may not consent even to medical treatment. They may not consent to a number of different, information sharing mechanisms that might help them along the way, even for court purposes and whatnot. And so that information is generally kind of shared by the social worker and or the clinician that's working with them off the bat, so that they're better able to understand some of those pieces. With colleagues, I think in our space sometimes it's implied, or there's a thought that people should know but often don't know. And I think that there's a recognition that more work needs to be done on that piece with colleagues. What I found is I think sometimes in our line of work, because the intent and the intention is there in terms of, wanting to help or being the helping professional, or wanting to advocate, that sometimes it's easy to kind of overshare or to have information kind of broadly reached in terms of sharing, that thinking that it's going to be advantageous or beneficial for the purpose of kind of everybody knowing that information, but that's not always the case, right? So even in terms of like things like if we're looking at like abuse history or family history or, medication information or all that, that's not always something that should be shared. And it should actually not even always should be shared. It shouldn't be shared. But I think because, again, helping professionals sometimes want to be in a place where they're like, this information could assist a person in being able to do their job better. Possibly, yes, but it also could be more harmful than helpful. And having colleagues understand that piece around why the confidentiality exists and why it can't be shared is definitely something that we have to do more work on. I think part of what we've been able to do a little bit better, which I was mentioning with some of my colleagues here earlier, is that in terms of the senior management team, so now the senior management team has myself and another clinical manager that is on it. And so that's helped significantly, because I think whereas before that information kind of was kept on the back burner, those conversations are happening regularly now, like on a regular basis, whether it be at morning meetings, weekly, manager meetings or whatever that might look like, to kind of highlight the importance of having these type of discussions, so that there's not this kind of, cloud over the topic or assumptions being made, but essentially there's more knowledge kind of mobilization in this area, whether that be through information sessions or meetings or whatever that looks like, so that there is an understanding of why we're doing what we do.
That's excellent. Thank you. Ashley, do you have anything to add to that as well?
A lot of it's been covered, but I just ensure that when I'm talking about consent with young people, that they're informed. What does that actually mean? What are you consenting to? What are the pros and cons of this consent? But also, what are those limitations? And I stress the point about safety, because oftentimes, even if the safety issue is not directly related to the youth, it's related to family or people in the community, and they need to know that in disclosing that information can be shared because somebody's at risk. Yeah.
So then there's sort of like a different approach, amongst the you as panelists, but really the end result is looking at the again, the obligation to the client, and knowing that there might be information that you have to keep reminding your colleagues that this is something that we can or cannot share. And again, what's that long-term outcome with the client, and then building that into a record and a documentation, and knowing that that can be shared, like was mentioned here about, getting a subpoena or something. They might have access to that information along the way. You don't know where that's going to go eventually. So being mindful, I think that's an important piece as well. Okay, that's great. Thank you. So we have a couple more questions here for our panelists. So let's start with Teresa. What have been some of the strategies that you have implemented to help protect client confidentiality? You may have given us some examples already, but if you have other examples as well, and ways to help protect, especially in the school board setting, I think that's interesting.
So many of our consults with school admin, social workers are a great resource in schools. So we may not necessarily always have to sit at a table at an in-school team meeting. Right. And administrators often have lots of questions about students and sort of needing support. So often we will do a no-name consult. And that could be done in an office. And so oftentimes we're just providing strategies or recommendations to administrators, and not having to go through a formal process. And administrators really appreciate that because it's timely, it's in the moment, it sort of happens. And the other things that we've done is we have an electronic system, so there's no more paper files where we're storing in filing cabinets. And we also always ask students where they want to meet. So often, if you can think of a school, we're often sort of going to the person at the front and sort of saying, can we see Johnny? And often in our informed consent process, when we're seeing students, we're asking, are you okay with that process? Are you okay with us walking in the office? Where else would you like to be seen? Do you want to do that virtually? What's more private? Times, etc. Right. So we put lots of things in place to ensure confidentiality.
That's excellent. Yeah, it's very true. And like I've heard that before too, with people calling and saying, there's the door that says social work or something, right. And the young person's going in there where you're trying to maintain confidentiality. Right? How do you do that when there's something on the door that says social work? So I'd love to hear from Michelle as well in terms of what are the strategies that you've implemented to help protect client confidentiality. I know we've talked about the logbox, but is there anything in addition to that?
Another thing that I think is really important, and I hope it pertains to this. In our communities, we have a lot of folks that need people to advocate for them, right? You could put anybody you want in your circle of care. It just has to be documented with consent. I think that's important, right? Mm-hmm. So we encourage, especially our elders, if you need somebody, let's get the consent filled out so that we can talk to your daughter, we can talk to your niece, right?
Right.
It protects the client's confidentiality because then we have somebody else we can talk to without having things to go kind of willy-nilly in the background, right? So that is a big piece. And another thing, like you say, we have, we've digitized everything. Our folks aren't, because we do travel, our people travel a lot in community. We're not hauling big bags of files around with us anymore. That was a huge, huge risk. Everything's done through our electronic medical record. So that's just a few things that we're doing.
That's helpful. And I know different family health teams, even across the province, also have different structures as well, where some social work information might be restricted and the doctor may not have access to it without consent. So there's so many different family health team models out there that I find. And our registrants want to find out again what the policies and procedures and across the board.
Absolutely. We're the health information custodian. So unless the client specifically indicates, I don't want anybody else to see my record, that's the only time we would lock it. Because honestly, goes back to my model of care.
Yeah.
It does impact the client.
Right.
If they can have everybody working with them, everyone in their circle of care have access to it, it makes a huge difference for client outcomes.
Okay, excellent. Thank you. Ashley and Alicia, I'll start with Ashley in terms of what any strategies around implementing, protecting client confidentiality that you haven't already covered.
In terms of when we meet with clients, we have our own private office that we do that. We don't require any youth service officers to be present. I mean, sometimes they'll come every 10, 15 minutes just to walk by, but otherwise it's a very private and secure space. Also, in terms of talking about confidentiality and ensuring that the team stays on the right track, we have biweekly team meetings where cases can be talked about and supervision can be provided in terms of what information can or should be shared and which information can't. I know that we have one specific example is we have a document that's called the clinical admission report, and sometimes there's questions around what can be included in there. And so sometimes we'll use our social work team meetings to discuss limitations and what's okay to put in there and not, and why. So there's a lot of checks and balances that go both in direct work with the youth, but also in working with the team so that everybody's messaging the same thing.
Okay, that's really helpful. And then I think something that Teresa had said too around consultation versus, going through the whole process of getting an open file and a, ongoing service. That's something that I'm not sure if at a facility such as yours that would also, if some other staff just say, hey, in this kind of scenario, what might this look like? And then you could offer some indirect support without having to breach confidentiality and or open a file. So that might be something specifically because it's not mandatory that, for social work to be involved. So I think that's also a great option for people in non-healthcare settings. So in terms of supervision, we want to talk about that because I think that we've noticed anyway, our registrants will say that they have some challenges around accessing supervision from a social work lens when it comes to your network of your team and knowing what could support you as a social worker. So if I start, maybe I'll start with Michelle in terms of, do you have any supervision strategies? I know you cover a large, geographic area and you have a variety of programs and services, and you also have multiple professionals from the healthcare environment. Would you say that there are supervision strategies that you and social work would put into place to really support your work?
We're fortunate that we have a really great mental health team. That's mental wellness team. That's what they're called. So they do provide supervision on a weekly basis to each other.
Oh, okay.
Which is wonderful because they can talk about real cases, real life.
Yeah.
Our crisis response team was just implemented 6 months ago. So they are social workers as well, so they can provide supervision to each other, which is wonderful.
Yeah, so that's really
wonderful.
helpful, right? Alicia, would you also have some kind of a model in place as well for your team?
Yeah, so in terms of some of the supports that we have, like as I mentioned, youth justice is quite a niche area for social work, so it's not very formal in terms of the consultation models and things that we have, but we do have an established relationship with the hospital, for the Sick Kids Hospital, and they are partners in terms of being able to provide consultation for various cases and or even just for knowledge mobilization purposes, which is a really great benefit to us, right? Now, unfortunately, we probably don't use it nearly as much as we should, but it is something that's available and accessible to us. I think what tends to happen a lot of the times is even though the information is obviously super beneficial, because the setting is such where it's so kind of unique, the examples or information or practical kind of strategies that are given are not always relevant to the setting. And so I think sometimes people shy away from utilizing those type of supports. However, I think that, we definitely need to use it a lot more. I think oftentimes we have to, consult with our kind of legal departments or counsel when it comes to things like, overlapping legislation and kind of what trumps what. Even when it comes to, confidentiality, privacy, sharing of information, there's been times where obviously because the legislation is federal, and then there's, the CYFSA, there's the criminal code, there's provincial legislation that then also comes into play. There has to be that discussion to kind of figure out what takes precedence in terms of how the information is shared. So the legal counsel and the legal department is often an area where we consult with regularly as well. Internally, we also have, as Ashley mentioned, mechanisms in place where we have case conferences, intensive review meetings for specific cases, and just kind of regular touch points and checkpoints so that information can be shared more broadly because it is such a large space. And there are so many different things come up on a daily basis that kind of consultation is required regularly.
That's great. Thank you. Is there anything that you'd like to add to that as well?
No, Alicia did a great job covering most of it. I know that part of the question was if we had people to bounce ideas off of, and that's we definitely do. There's, anything that I'm not sure of, I could either have a conversation with Alicia, or there's multiple disciplines available at all times to have those conversations. So meetings, if there's any uncertainty, I have to say that we're very good at the Royal McMurtry Youth Centre in terms of coming together and having a brainstorm about how to navigate certain difficult situations.
Very helpful. Interesting. Just to
So we have similar models. We have, legal that we can bounce ideas off of. We have supervision to social workers once every 4 months is what we aim for. Of course, they could always reach out to a coordinator or a manager of social work in the moment, should they have a situation that they need to problem solve. They also do peer consult. So each area, so we have 4 areas within the board. There's 11 social workers in each area, and so they've developed their own peer consult, and that's done once a month. And a pitch to the college. We often have the college come out and we problem solve cases and scenarios that come up.
Us on our toes. It's all good. And I think it's also great when we hear about, even across provincially, that there are advisory groups or, communities of practice that exist that you can, again, it doesn't have to be supervision and confidential information, but it's overall social work practices and social service work type programs and services that are helpful in your setting that can be kind of discussed across the board, which we've heard of, and it seems to be a great way to also have those connections for people. So that's great. And then we do have one last question. I know we're doing more time. And so we have my last question is really, is there anything else that you want to add? Just in terms of working in either a non-health setting or a multidisciplinary environment. And, if there's any other challenges or additional, information that you'd like our registrants to know. Like I said, this comes up frequently for us at the college. And, people trying to figure out how to get appropriate supervision or how to navigate privacy information. Sometimes there's privacy officers out there, too, that exists within organizations that we direct people to. But is there anything else that you could help our registrants understand in terms of how you navigate those challenges of confidentiality? And, maybe I'll just start with Michelle, if that's okay.
Excuse me. Okay. So I am the privacy officer for our organization, and I
like that connection.
But honestly, I think it's really, really beneficial. We are a small organization compared to you guys. We probably have 150 employees, so quite small. But I probably get at least 20 phone calls and probably the same emails about privacy questions every day. So I'm not trying to toot my own horn. I'm just saying there's always privacy questions, and our staff is always coming, and I always tell them no question is stupid, just ask it. And if I don't know it, I'll find it out for you, right? But I don't know how many other organizations have that available. Most healthcare organizations have a privacy officer. So, Eddie, I do think it's a valuable thing for your people to be able to come.
For sure, that's really helpful. And even we talk about legal consultations sometimes too, but then we find some of the organizations that are not healthcare settings, their legal consultants seem to have a different sort of priority over, like, in terms of risk management and how to navigate an organization's, challenges versus the privacy legislation that you fall under in your day-to-day practice as social work. So that seems to be, and we talk about professional liability insurance and how individuals can access their own, so you can get some legal advice if your organization is strictly focusing on how to navigate or mitigate risk from, organizational structure versus social work. But I'll throw it back out there to say, Teresa, is there anything that you want to add, anything that you'd like the registrants to know about providing those services?
I think what has helped us in education, we're a massive organization. As I said, with running into and having conversations with multiple people, I think what is important for social workers is really to keep clients at the center of the work. And also asking questions if you don't know, like really, truly don't make assumptions. There are so many legislations you have to sort of keep on top of and be thinking about, and not assuming that you know it all. Because it's so hard to keep up to date with all of it. And I think just ask questions, and eventually we'll find the answer.
Thank you. That's very helpful. Sure, Ashley.
Yeah, I kind of echo the sentiment, right? For us, like, no 2 days are alike. And so to have like a clear-cut answer on anything is probably not something that we generally tend to have. There's a lot of, and I think one of the big things that we do often is consult. There's no reason that we should be making like unilateral decisions or even, having that thought that we have to do that, because there's a lot of support and or resources that are available for us to be able to kind of, get the answers that we need. And sometimes it's even things that we might not even consider, right? So like, we're talking about healthcare in some settings, but things like programming too, right? For us, it's like, okay, well, an organization wants to do a program with a youth, but is it okay for their name to be published, or is it okay for, or do they need consent because they're under 16 in order to participate in the program? So things like that often come up on a regular basis, where we have to make sure that we're consulting and not taking the provisions for granted, right? And because it looks different for every single situation, I think it's one of those things where we, again, consult as much as we can and try to find the answers as they are to the questions as they come. And yeah, there's no one-size-fits-all approach, right? And so I think it's one of those things where discussions like this, it's really good to have them on a regular basis, so that persons that are from other, areas within the field are able to understand. And I mean, I've learned a lot today as well from being in this space as well. So ask questions, and hopefully we'll all get the answers we need.
Excellent. Ashley, would you like to add into that?
Just that what helps me kind of navigate some of the trickier situations is to understand that there are different expectations across disciplines. And so when working in a multidisciplinary team, part of the way to be effective in doing so is a respect for other people's parameters and what is going on for them in terms of what they can and cannot share, and also empowering the youth to provide consent insofar that they have the capacity to do so.
Excellent. That's great. I think we've all learned something today for sure. I don't know if we have some questions that we've got coming in, but I just briefly thank you. Very, very helpful. And like I said, we're learning a lot today, and we will continue to learn and see what other questions can help our registrants as well.
Thank you for that. And we do have a few questions that I've been noting down. I will just say there's been some great comments thanking all of the different panelists coming today. One in particular saying thank you for having someone from a correctional facility. Balancing confidentiality and correctional policies is a huge challenge in corrections. There was another comment thanking again around the circle of care, that the circle allows a safe place to be supported and a wraparound client and culture-centered approach. So thank you for that. So we have gotten a few questions. One of them is directed from a school setting approach. Someone asking, what happens if the child in the school setting already shared the information with the teacher before sharing it with the social worker? And I might add that someone did comment in a response to say that they would likely thank the teacher for sharing the information, but just noting that it's not their story to share. Wondering if there's maybe a response to that.
Sorry, am I understanding that a student shared the information with the teacher? What would happen in that case?
Yes, correct.
And the teacher's approaching the social worker?
Yes.
I like the response that was provided, because we would do exactly that. We would say, thank you for sharing. You know, there's always good intention when teachers are sharing information. It's because they care. But wondering if we could loop back and have the student come down and sort of give voice to the student and share their own concerns, and educating them about how to access support might be helpful in that case.
Thank you for that. There's a question generally to the group. Any advice for environments where you are the only social worker or social service worker available?
That's isolating. I would go back to Sue's comment. I would hope that there would be committees or advisory groups that someone who works in isolation could access from time to time.
Yeah, I agree. Yeah, I share the sentiment. So although we have a larger number at our facility, there are facilities that are in the north, because there's 5 direct operated facilities that exist for the province. One of them being in Thunder Bay, one being Sault Ste. Marie, one being in Sudbury. And so those facilities tend to have either 1 or 2 social workers that are in that space. And what has been helpful, which I didn't get a chance to mention, is that there is a community of practice that exists for the direct operated social workers and clinicians, where it's the corporate unit that created it, but essentially, you know, they're able to kind of meet, whether it be, you know, via Teams, via virtual meetings or whatnot. And there was even the impetus to kind of have like once a year in-person meetings so that everyone could kind of come together and both have like learning attached to it, but also be able to speak about specific things when it comes to cases or specific examples that needed some type of consultation. So I do believe that model really helped them, because they had indicated in their feedback that it was something that was very helpful. So if there is the capacity to do something like that, as small as it is, even if it's like a virtual forum, at least there's kind of real-time dialogue that's able to take place when there's things that come up that require some type of consultation.
That's great. Thank you. Did Michelle, do you have anything to add to anything to that? Or, yeah. And Ashley, good stuff. Yeah, I think that it's the same idea, right? You want to make sure that there's access to somebody. We talk about even that clinical supervision piece, even if you have to access it outside. So sometimes registrants will ask us, and they'll say, you know, where do I find some support or help? And you can purchase services for clinical supervision as well. But I think you have to look at your big picture organization and policies and procedures and how those kind of like matter, you know, in the work that you do, so that you're not focusing in one area or the other when you're not. Instead, look at the mandate of your organization, because we will say in our standards of practice in Principle 5, you know, we talk about ensuring that you do follow the policies and procedures around confidentiality that your organization has set with collection, use, and disclosure. So that being said, you might still want to seek some additional support from the social work community. Right.
Thank you for that. And I know it was mentioned briefly, but I'll maybe throw it over to you, Sue, maybe just for registrants tuning in today, because we do have quite a high number of attendees watching today's session, to talk through some of the opportunities and services provided with the professional practice department around, helping problem solve cases and challenges, and what supports that you as college, as the professional practice staff, have with that.
Well, I mean, that's a broad-based question, because we do a variety of things within the department that, you know, supports and guides our registrants, but we don't get into clinical examples or any kind of specific questions that should be addressed by a clinical supervisor. So we'll have consultations with groups of social workers that we're addressing specific topics. So aside from confidentiality, we could talk about other things such as documentation or virtual practice, etc. So we might meet virtually or in person with groups of social workers. And we do, of course, the phone, virtual, or email consultations on these topics. But again, if there's anything specific around clinical work, settings that involve various therapy and modalities, we can't speak to that, and we would redirect people to focus on the best practices in their community, any evidence-based work that's been done, and to seek support from their colleagues and other avenues, whether that be through their own supervision or their managers, etc. And we do reflect, of course, on the standards of practice. We talk about making sure that they're aligning some of their conduct, following the standards of practice. And I think when it comes to privacy in particular, and if there's any kind of challenge that they're having and they don't know how to navigate confidentiality and they feel that their organization is not supportive of their ability or their attempts to keep things confidential as per legislation, we would just say, you know what, you do your best, advocate for those workplace settings that align with legislation and with the standards, practice, and code of ethics, and just do your best to remind your organization what your responsibilities are as a health information custodian and someone who's responsible to follow the Personal Health Information Protection Act. Mm-hmm. Yeah.
Thank you for that. There's a question regarding work in remote areas. So when working in remote areas, is virtual supervision, such as peer or group supervision, acceptable?
I mean, that might be a question for you, but I know you work, Michelle, in a remote area. Do you have any challenge? I'll start with that, and then I can bring it back to the college perspective.
I don't think we're remote enough.
Okay.
Because
okay.
We basically, our social workers are kind of divided into East End, West End. Gotcha. And, Sault Ste. Marie's here and Sudbury's here. So we do have, we're not that remote.
Gotcha.
Again, like everybody else did during COVID, we just
yes.
we did rely on that. But if we can't do in person, Zoom is good, but in person is better.
Right. Is there any other comments or feedback from that for that question? No. Okay. I mean, from our point of view, we would say supervision that aligns with your social work practice would be ideal, whether that be virtual, in person, group. Sometimes we say based on your area or your amount of time in the field, you might need more frequent supervision, and then as you become, better equipped to do your practice, you might not need as much supervision. And we actually talk about that in the guidelines to the controlled active psychotherapy, for example. So if more than 3 years, less than 3 years, we kind of give examples of what supervision could look like, which is really, really helpful. When we talk about groups, and some people use the term, and we're trying to help people understand that peer supervision doesn't exist. You can't supervise your peers, but you can consult. Mm-hmm. You might have one person that oversees a supervision meeting with peers, and that's fine, but you can't. Peer supervision in and of itself is a bit of a conflict. I mean, how would you document your supervision? You're working with somebody and the next day you're supervising them. So I think it's terminology that it's just one of those things. So we just try and inform people that peer supervision as a term doesn't really apply when it comes to supervision. It's more group consultation, peer consultation, group supervision, or of course, individual supervision.
Thank you for that. We have a question about a term that was noted during the panel discussion, wanting someone to explain the no-name meeting.
That was me.
Yeah.
So the no-name consult. So what happens is, I'll give an example. An administrator would approach me and say, hey, Teresa, we have a student in a classroom who's presenting with behavioral challenges, wondering if you might be able to provide recommendations or suggestions to support. And the reason why we do no-name consult is because the reverse can be quite onerous, could require a length of time before a student could get a recommendation. So we do no name consult for time, really.
That's helpful. Thank you. I think that leaves us with the question period. I see lots of thank yous going on in the chat, and I am going to read out one comment that I thought was great to share broadly. Such a purposeful, interactive team gathering today to acquire knowledge, receive guidance, to enhance our performance and our practice. Forevermore appreciative, and thank you to you all. I think I will leave it with that.
Sounds just wonderful. Well, we're grateful, to have you here joining us. So I would absolutely reiterate that. So much appreciative, because these are questions that come up all the time. So thanks so much.
Thank you. And I will just end it noting that as a token of our appreciation today, the college has made a donation specifically to the Indigenous Women's Fund of Canada. Thank you again for participating in this year's Ahmed.